Thank you, organizers. It's a very, very pleasant change of mind being out of that hustle bustle of Bombay to the peaceful city of Nadiad. The moment I entered the institute, it was such a refreshing experience. It felt like a retreat. So thank you so much for letting me be here. And thank you for choosing this topic. So let me walk you through the story of Asha Kumari. Name change, she is actually a real patient, and we will see her photo at the end. So she comes to our lupus OPD. She is a 33-year-old lady with a known case of lupus with lupus nephritis. She has been with us for last 3 years with class 4 lupus nephritis. We have treated her with urolupus, followed by MMF, which is our UNIS protocol. And now she is in partial remission. Her creatinine is 1.6 and her proteinuria is 900 milligram per day. She is hypertensive and is now on 2 drugs. Raise of hands, how many of you would actually be okay with her getting pregnant? Thank you, sir. So many a times we don't have this option. Many a times, despite every effort from our side, they are very, very anxious to conceive and they come to us with pregnancy. But sometimes they actually are counseling works, preconception counseling, and they want some answers. So the most important question which any women with glomerular disease will have are these three. I'll be using the word women throughout my talk, but nowadays it's a problem to use women, so you can think of it as a person in your mind when I talk about women. So these are the three questions which commonly patients have in their mind when they think of pregnancy and when we are doing the counseling. And we'll be talking through what they are thinking and what we'll be doing in the next 20 minutes. So in these 20 minutes, 20 or 30 minutes, I'll be covering these topics. What are the principles of risk assessment in a woman who is having a glomerular disease and is now contemplating pregnancy? So we'll talk about some disease-specific outcomes in which there is evidence. Lots of diseases we don't have still evidence. We'll talk about what happens if pregnancy has happened and there is a de novo glomerular disease coming up during pregnancy, and we'll see how we'll manage these patients. For the want of time and for sake of brevity, we'll not be considering fertility and sexual dysfunction, which is a very, very important topic for glomerular diseases patients. So, first question which Asha Kumari asks me in my lupus clinic when she is very anxious to conceive is this: will pregnancy harm her kidney? How likely is she to end up with dialysis after having a pregnancy? So, we all know that kidney function is very closely, very strongly affected with pregnancy, and how bad or how good will she come out with after having a pregnancy depends upon what is her baseline kidney function. So, her CKD status. This old study but still relevant from 2015, 504 pregnancies from Piccoli from Italy. She has done this prospective cohort study, and the problem with this study was that 50% of the patients did not have a baseline creatinine. Now, it is very important to understand that when you don't have a baseline creatinine before pregnancy, during pregnancy, the decline, the dip, normal pregnancy dip which happens in creatinine can be considered a baseline. And then if you compare the kidney function from the first pregnancy creatinine level, it might look that it is falsely elevated. So that is a caveat for most of the available literature today in the sphere of pregnancy and CKD of pregnancy and glom disease. Many studies do not have a baseline creatinine, and that's why it might appear that the CKD progression which is attributed to pregnancy is not actually due to pregnancy. It must have been a baseline CKD which was missed. So as we can see very clearly in this patients, there were few patients in CKD stage 4 or 5, but there is a significant risk of new onset hypertension, new onset or doubling of proteinuria, and also RRT in this group, and the risk increases as we go on with increasing stages of CKD. We all know that pregnancy is a stressful state for every organ in the body, including the kidneys. However, normal healthy kidneys can go through multiple pregnancies, 6, 7, 8, 10. We have seen multipara up to like 6, 7, 8, 10 with coming out with a healthy kidney. However, when the kidney is already scarred, this physiological stress is something which can cause a permanent damage to the kidney. And this was proven in this older study in 2012 it's also coming from Italy. We'll be seeing how it affects. So the most important thing which we need to consider while thinking what will happen to kidney post-pregnancy is the CKD stage to begin with. It has been proven in multiple studies, including this systematic review, that if the patient is having CKD stage 1 or 2, the risk is minimal. So while counseling, we should also be aware of this, that we should not over-counsel. Not everyone who has Glom disease or CKD is not unfit for pregnancy, and we should remember that the risk is directly proportional to the baseline renal function. But what happens with advanced CKD? The story is not that rosy with advanced CKD. This wonderful study from 2020 by Kate Willey's group from England, and they evaluated 178 pregnancies, and they beautifully demonstrated that what happens if an advanced CKD patient gets pregnant. This is what happens. For example, if someone is here, if you have not been pregnant, usually our normal GFR decline slope goes like this. However, during pregnancy, the GFR decline, the slope of the GFR decline becomes steep, and we start losing GFR much more faster than what we would have lost when we would not have been pregnant. How faster? So this is a very nice mathematical calculation which was done by Kate in this study, and they told us that if someone would not have got pregnant and would have had stage 3A CKD, the kidney function which they would have retained for 1.7 years, if with a normal course of progression of CKD progression, they lose that much function during their 9 months of pregnancy. And that becomes to almost 5 years if they have CKD stage 4 or 5. So if my kidney function was 50 now, and 30 now, and in 5 years it was going to be declining to 15, during 9 months only it will decline to 15. So this is the years of normal kidney function we are losing when we are getting pregnant with an advanced CKD. This is a very important parameter which we should keep in mind while doing the preconception counseling of patients with advanced CKD. But will every single patient lose this kidney function? Even in this study, there were patients with CKD stage 4 or 5 who did not lose kidney function at that rate. So what are the predictors of eGFR decline in advanced CKD patients? Chronic hypertension, a higher gram of proteinuria, and a very, very important predictor of gestational fall of serum creatinine. This is one single parameter which in recent studies have shown that it independently predicts how well you can come out of the pregnancy with your preservation of kidney function. The first question you should be asking yourself or to the patient is that, what was the creatinine to begin with, and is there any dip happening in the mid-gestation? If the dip is happening in mid-gestation, that it's like a surrogate marker of all those physiological changes which the body innately has to prevent you from getting a permanent damage due to physiological changes of pregnancy. And that's why absence of that mid-gestational fall in creatinine is a predictor of permanent eGFR decline in patients with chronic kidney disease. Apart from that, this nice study, again now little old, but nothing has replaced that, so that's why it's here. This person did a beautiful study in 50 around patients, and he divided them into 4 groups. People with high proteinuria, low proteinuria, high GFR, low GFR. And as we can see, this group did worse. Not rocket science, also common sense. This group will definitely do worse. Also, it is important because we are in a glomerular disease conference, and it is important to note that even with a preserved GFR, when you have significant amount of proteinuria, you are still losing eGFR due to pregnancy. You are worst when you are here, but even in this case, when your GFR is okay but proteinuria is high, you are still losing GFR. So now that was how we counsel them about loss of GFR. Now what about pregnancy-related complications? So what does pregnancy do to her health and for her fetus? Maternal-fetal outcomes also depend on CKD stage. However, it is important here to understand that while we were talking about kidney function, CKD stage 1 were pretty safe, but they are not that safe when we talk about maternal-fetal outcomes as compared to controls, that's people with normal kidney function. Even CKD stage 1, like 1 is, we don't even consider, nephrologists don't even consider 1 as CKD. So even with CKD stage 1, they had a higher risk of preterm delivery, lower gestational age, lower fetal birth weight, small for gestational age, and NICU admissions with a pretty significant increase. So maternal-fetal outcomes are worse even in women who are CKD stage 1 when we compare them to general population. What happens to CKD stage 1 or 2 in terms of their odds of getting these complications? So the odds, almost all maternal complication odds are significantly higher, and this starts as early as CKD stage 1 or 2. Then what happens when we move from the spectrum of 1 to 2 to 3 and 4? Obviously the risks become higher, as high as around 88 or 89% of women who are CKD stage 4 or 5 will be having a preterm delivery. Their average gestational age will be around 32 weeks, and they will give rise to a low birth weight baby. The numbers are small here, so that we'll have to consider. This so to compensate for the numbers, Michelle from Canada, she is like the most important key opinion leader today in this topic, has done this very beautiful study where we have adequate numbers. So now you can have adequate numbers. This Piccoli study had poor numbers from Italy, but this study from Canada has very good numbers. Registry database data was calculated from the registry. 139 patients with eGFR less than 45, and very beautifully shown that with declining GFR, the probability of having severe maternal morbidity increases, and the probability of preterm birth or low birth weight increases. So much so that it goes to as high as almost 40% in patients with GFR less than 45. Here it's written severe proteinuria, but this severe is not severe. It's maybe Canadians take severe little differently. So it was around 1 gram for this group of severe proteinuria. So, and it was around 500-ish in moderate proteinuria, and mild to minimal was around 300-ish. So anyone who has around 500 or 1 gram proteinuria also is at high risk of developing at least one maternal morbidity indicator, and similar risk for preterm delivery and worsening of proteinuria. So coming back again to the Kate Wheeler study, they found that 98% of these women with advanced CKD do have a live birth. So that is a reassuring thing. You can tell that there is high likelihood that you will go home with a live baby. However, there is significant risk of hypertension, and there is significant risk of proteinuria worsening. So now, in which patient really these problems will happen? So the consensus today, this is from a consensus document which we'll be discussing later, is additive. The risk is additive. All these independently affect and they add on. So if you have a GFR or lower GFR plus proteinuria plus hypertension, you are at the maximum risk. Vis-a-vis, if you either have one of these, the risk is little bit less. Plus, the type of glomerular disease also plays an important part, which brings me to the next topic, which is what is the disease-specific outcomes of pregnancy in glomerular diseases. Lupus nephritis, it's the most well-studied, lots of data available because it's the disease of women of reproductive age group, so they tend to get pregnant. Also, lupus in its own right does not very, very strongly hamper fertility as compared to other glomerular diseases. So we have lots of data on lupus. That's a good news. Less Indian data, but still lots of data. So I have chosen two studies where I could contrast between what happens when lupus is very well controlled versus what happens when lupus is active. To show you, first study coming from I think it's from US, I guess. This study shows us that when patients are having active lupus, almost every complication to the mother and to the child is very significantly high, to the tune of around 20% unsuccessful pregnancies, 16% hypertension, very significant risk of flares, and active nephritis. It also tells us, this study only did, so they have a very good number, 1842 patients, in which 1000 had historic nephritis, like it is now well controlled, and 490 with active nephritis, and they did a comparative analysis of these two. So in meta-regression, we found that hypertension and preeclampsia were significantly more in patients with active nephritis as compared to those who have history of nephritis. Vis-a-vis, what happens when you do your work properly as a nephrologist? You control the disease and then the patient gets pregnant. So this is an Italian cohort, 71 pregnancies, and you can see it's like a testimony of the disease being very well controlled. GFR is good, proteinuria is it's just 0.4. Prednisolone doses are minimal. HCQ, almost everyone should be getting them, but they are not getting them. But in this study, the numbers are much more reassuring as compared to the previous study. So this proves that when you control lupus nephritis well, the outcomes will be much better than when it is an active disease. How do we control them, and how do we know that the disease is actively controlled? Is by these parameters. We go through SLEDAI, we check active nephritis, like in the, you can spin the urine and see for active sediments. We check the proteinuria, blood pressure, and previous renal flares. Presence of hydroxychloroquine, stable treatment for at least 6 months, is known to decrease flares and is also known to give rise to better pregnancy outcomes. Presence of any out of the three positive APLA antibodies is a poor outcome when the patient gets pregnant. Just club them as modifiable versus non-modifiable and club all the studies together because it was too much to be discussed individually. These are the parameters which you should be thinking, and it's like a checklist you can put in your lupus clinic, and then when all the boxes are ticked, then the patient can go for a successful pregnancy. Have put this slide only to show you that patients who are, this is PROMISE study, I'm sure everyone is aware, a very like a landmark trial in this realm. Even when there are no risk factors, what are the risk factors? These are the risk factors which we know cause a poor prognostic outcome in pregnancy. Even when there are no risk factors, absolutely none of these, still 7.8% women have a poor prognostic outcome when they get pregnant with lupus. Moral of the story, they are at risk, monitor them closely, don't relax till the baby is really out in your hands. Same PROMISE study, they found out the predictors, and in their study it was low C4 and the history of remission, of course, which independently predicted prognostic outcomes in these women. One word about neonatal lupus, not uncommon. We have had, like in my short span of 8 years or something, I have seen 4. All 4 of the bachus died despite putting a intracardiac pacemaker. Not very uncommon. Think of this. Look for this. Two patients were missed. The baby had bradycardia, but they could not be diagnosed in time, so they died because of that. 2 were diagnosed in time, but still succumbed. Hydroxychloroquine significantly decreases the risk of this complication, that is neonatal lupus. And echocardiography from 16 weeks is recommended. However, this monitoring is controversial. It has to be decided upon the resources available in our setting. Coming to ANCA-associated vasculitis, this is not a disease of reproductive age group. It's a disease of elderly. We have very, very less data. So this it's a systematic review which tells us that, again, things which we inherently feel are important. Baseline hypertension and baseline kidney function, they are closely associated with ANCA-associated vasculitis and pregnancy outcomes. IgA. Apart from lupus, we have a good amount of data for IgA, and the good news is that it is quite reassuring. Lots of studies, even Asian IgA is supposed to be more aggressive than Western IgA. We don't have Indian, but we have data from Japan, we have data from Hong Kong, which says that IgA nephropathy does not have very poor outcomes in pregnancy, though the risk of hypertension is high because IgA is inherently predisposed for getting hypertension. But the live birth weight, the rate of GFR progression is not that bad. So IgA pregnancy, watch for hypertension closely. Lots of studies are discussing now what to do about ACE-ARB in patients with IgA, because that is one of the mainstream of treatment with IgA. if you don't want to get into the steroid side effects, including budesonide. So we'll be discussing them at the end. But IgA pregnancy data is little reassuring as compared to the other diseases. Complement-mediated diseases, specifically HUS in pregnancy, again, data is quite sparse. This is one of the initial data with Fadi Fakori's group. What they have done is from Switzerland. What they have done is that they studied 100 patients with complement-mediated HUS, and out of which 21 had got pregnancy-associated HUS. That means that when they have a baseline HUS, they get pregnant, and then they have a pregnancy-associated HUS in the peripartum period. 35 of them got pregnant and did not have pregnancy-associated HUS. All of them had poor outcomes. However, there were no difference between these two groups. People who got pregnant and pregnancy-associated HUS, and who got pregnant with no pregnancy-associated HUS. An important thing to remember is that, at least in this study and also in some observational studies, second pregnancy is the one in which flare is most common whenever we talk about HUS. Maybe Dr. Lobo sir can tell us more about this at the end. Systematic review, which tells us that this disease should be treated with eculizumab. We'll be discussing drugs at the end, but eculizumab is safe in pregnancy. Now data is building up. I'm not saying it's completely safe, but whatever data today in 2025, it is safe, and when we treat, the response is better. Pregnancy-associated HUS treated is showing remission in 88%, and untreated is showing remission in 57%. And you can see the renal failure, death, or dialysis significantly higher in group which is not treated with eculizumab. Nowadays, we are having access to eculizumab, so we should try to make it more accessible in our country, and we should prioritize these women for treatment with eculizumab. Membranous nephropathy, again, similar risk factors. Heavy proteinuria, severe hypoalbuminemia, positive PLA2R, and no remission during pregnancy. High PLA2R is defined differently in different studies, but it is usually consensus that a 3-digit PLA2R is very, very strongly associated with poor pregnancy outcomes. Other GN, we don't have much data, but FSGS, we do have some data, and it is not very reassuring. It progresses through pregnancy. One of the worst diseases to have with you as a pregnant patient is diabetic kidney disease. It's like worst with all the parameters combined. Highest rate of fetal and maternal complications. Their nephropathy can worsen and their neuropathy can worsen. Retinopathy definitely worsens, but again, data is very, very scarce here. Diabetic kidney disease, we need to be very cautious while getting them out of the pregnancy. How do we manage these risks? Now we know all the risks. Now let's try to minimize them and give a positive outcome to the family who's very anxious to deliver. These recommendations have come out in 2023, and they are the most latest one. Hart Fakori and Fakori is the senior author. They are the torchbearer for most of the studies here. The effort should start much before the patient conceives. The most important role of a nephrologist comes in the pre-conception time, when we counsel them for all the risks and prepare them for pregnancy. Antenatal care is very important. Again, we monitor the disease, monitor blood pressure, monitor fetal well-being, and choose correct medications which she'll be getting for the 9 months. And postnatal care is definitely important, because this is the time when we should be addressing the GFR loss which must have happened because of the pregnancy. Pre-conception counseling, nothing, I can't specify it more. The most important thing to do with your patients, sit with them and make them understand what are the risks, what they can do, what you can do for decreasing those risks, appropriate adjustment of medications, and stabilizing the disease activity are the key points here. We do have lots of barriers for a good pre-conception counseling, but we can't replace it. So we have to strive to make sure that the message which we are stating gets across to the patient in the most effective manner. Now we have a patient, we have done pre-conception counseling, and a patient has DN, and now she gets pregnant. No, she doesn't get pregnant. She is with you, and you are trying to get her pregnant. You are trying to get her to pregnancy. So what all you will be looking at? It's first of all, you will be looking at disease markers. With MN we have PLA2R. Pla2R in remission is a very strong marker of MN remission, so do monitor it very, very closely. For lupus, you have anti-dsDNA. Remember, patients have lupus, active lupus with no dsDNA in their blood. So if they have had dsDNA positive in their prior history, only then it is a marker of activity. There are patients who have dsDNA negative and they are in flare. In those, dsDNA is not a marker of activity. Patient is in remission for around a year with no immunosuppression. That is the best patient to have. Lowest risk. They can go ahead with pregnancy, and most frequently that will be a cakewalk. Patient who has been in remission but it is less than 1.5 years and is on immunosuppression is at medium risk. And people who have active disease and who are having a deteriorating kidney function, they are the highest risk possible. You should try everything possible under the sun to not get this group pregnant. But then we are not very lucky every time. They do come to us with a pregnancy, unplanned of course. So then what do we do? So in these two groups, what we do pre-pregnancy is that we assess their baseline immunosuppression. We stop all the teratogenic drugs and then we observe them without those drugs for at least 3 to 6 months time. And then we see what is happening to them. Once they get pregnant, before 12 weeks, we usually start at 8 to 10 weeks. We add them on low-dose aspirin because that is known to reduce the risk of preeclampsia. What if the GN is discovered de novo in pregnancy? The most important thing which will help you here is that to have a baseline proteinuria in first trimester. Anyway, ACOG, all the OBS-GYN guidelines recommend having a urine routine in first trimester. For ABU screening, it is also helpful for proteinuria screening. If it is coming less than before 20 weeks, then it is mostly because of underlying kidney disease. Preeclampsia usually come with hypertension. That will also differentiate these two. So what will you do if someone is more than 20 weeks and now they are pregnant and they come for the first time with any report suggestive of GN? If they are having isolated microscopic hematuria, just observe. At least 20% of women do have this in pregnancy. You can just continue monitoring and deal with it postpartum. If they have proteinuria along with hematuria or isolated proteinuria, do everything possible to know in a non-invasive way to diagnose the cause of proteinuria. You can do Pla2R, ANA, dsDNA. You can do complete complement panel. Dr. Lobo will help with the CH50, AH50 also if need be. ANCA, anti-GBM, everything non-invasive should be done first. We should be looking at what is happening to their proteinuria and we should be serially monitoring them. You have time till 22 weeks. Before 22 weeks, biopsy is pretty safe. So till 22 weeks, try to do whatever non-invasive test you can do to get to a diagnosis of the cause of proteinuria. Apart from that, if the patient is severely nephrotic, definitely consider nutritional management, diuretic therapy and thrombosis prevention. Thrombosis prevention is mainly for women who are either having a diagnosed membranous nephropathy or very, very low albumin or having an APLA positivity. Then once this is established, patient is stabilized, then comes the question of biopsy or no biopsy. So before doing biopsy, just ask this one question, whether biopsy is going to change your management in any way. After 22 weeks, biopsy has a significant risk of complications, bleeding, preterm labor, microscopic hematuria requiring blood transfusions. They are significant after 22 weeks. So if you want to biopsy before 22 weeks. Don't sit and wait and let the patient progress through gestation and then think of biopsy. If by 22 weeks there is no reason to biopsy, then don't biopsy. What we do, when we biopsy in GN during pregnancy is when the creatinine is worsening and the proteinuria is doubling, and we have a reason to believe that there is something which will not respond to only baseline blanket immunosuppression which we will be giving, something like a vasculitis. So this will be the immunosuppression which you will be giving. You can give them a trial of steroids and then SOS, AZA and tacrolimus it will come next. Before biopsy, these are routine things. I am sure we don't need to discuss this in this August audience. We need to rule out everything possible and try to make the biopsy as safe as possible for a pregnant woman. Now, someone has either a proteinuria or has relapsed in pregnancy. So now what do you do? So biopsy may be rarely indicated if the GFR is rapidly declining or there are any systemic features like of a vasculitis. If the patient is having any of these primary or secondary GN, and they are on these stable medications, these are the drugs which are definitely your go-to drugs in pregnancy. You can just continue them and continue monitoring. We maintain the maintenance immunosuppression, and if there is a good remission, then there is no need to give a maintenance only because the patient has got pregnant. You can just observe the patient. However, if there is relapse and the patient receives an induction, the best possible induction is steroid, high dose corticosteroids. Then the first and the safest available is azathioprine. Next will be CNI. CSA is more studied than tacrolimus in this setting. Third is rituximab. We'll be discussing what is the problem with rituximab. HCQ needs to be continued. There are some studies of HCQ in IgA nephropathy coming from Japan, where they say that HCQ in IgA is good for pregnancy. So this is something which you can think of in your patients. Immunosuppression in pregnancy, we all know steroids are good. Dosage should be less than 20. There is some risk of GDM, so screen for GDM. Stress dose of steroid needs to be given at delivery. This is a debatable topic. Many researchers in present day are advising against it. So that is something which you can tailor according to your patient, seeing their weight, their sugars and all that. Tacrolimus, again, no risk of congenital anomalies. A significant risk of hypertension, GDM and AKI with neurological toxicity. Something you should be monitoring these patients for. We'll discuss about TAC levels in the next slide. Azathioprine, again safe in pregnancy, your go-to drug in a relapse. Mycophenolate mofetil, very significantly nephrotoxic. Stop 6 to 12 weeks prior to conception and switch to azathioprine, and it is generally discouraged also in lactation. Sirolimus, everolimus, less data, but whatever data is there, they advise us to stop 12 weeks prior to conception. Vilatocept, again, some recent case studies are saying that there are no birth defects and it can be given in pregnancy. If you are out of all the other options, you can discuss the risk benefit with the patient and then go ahead. Rituximab. Rituximab is nowadays more commonly being used in pregnancy by hematologists, specifically in the setting of pregnancy associated TTP or TTP which gets flare in pregnancy. So IgG can cross placenta only after 12 weeks of gestation. So what is recommended, at least for TTP, is that you give it initially in the preconception period. The effect will last for almost 3 to 4 months. Then you stop it, and after 12 weeks of gestation, again you can start it. It is also important to remember that in a mother who has received rituximab, the child will not develop vaccine response for at least 6 months. So all the vaccination schedule will have to be rescheduled accordingly. So that is the state where we are at rituximab. Eculizumab, like we were discussing, atypical HUS, complement-mediated HUS is very harmful for kidney function. Many of them end up with end-stage kidney disease, and eculizumab is something which is known to prevent that from happening. There is data building up specifically from PNH which says that this is safe in pregnancy. Small cohorts have been treated in France and Spain, and they have shown good efficacy and safety. Again, something which we need to sit with our patients across the table and discuss. TAC levels in pregnancy, this study in 2017 changed practice initially, which showed that actually TAC levels go high, whole blood TAC levels. However, it is not justified to increase TAC doses. What we monitor is whole blood TAC level, but what is actually helping the patient is unbound TAC level, and that is not reduced in pregnancy. That is actually high. So if you just monitor TAC level and keep on increasing TAC doses, your patient will end up in hypertension, and actually it has been shown in transplant population that this is linked to increased risk of preeclampsia. So do not increase TAC dose if there is no other clinical indication of doing that. Only do it only based on the TAC levels. RAS blockers in pregnancy, again very very important drug for someone who does not have any other drug to be treated with in their armamentarium, like diabetic nephropathy. SGLT2 again is not yet approved for pregnancy. So what we follow is that we give that, if it is really to be given, we give it till conception. Don't need to stop it before 6 weeks, 4 weeks, 8 weeks. Also remember that all the side effects of RAS inhibitor which has been described are there in second or third trimester. In the first trimester, it is pretty okay. Also remember that most of our patients are having infertility. So if they plan to conceive today, they'll not conceive today, they'll conceive after 6 months, 8 months, or we don't know when. Or all these time, if they are without RAS blockade, that's not a good thing for pregnancy anyways. This study beautifully shown that when you get pregnant with 4 gram proteinuria, you conceive, you come out of almost 10, like much more proteinuria than what you had it was actually 10 gram for this patient. And with less proteinuria, if you conceive, the risk of worsening in diabetic nephropathy also was better. So try to optimize RAS inhibitor as much as possible. Don't be scared of its use immediately pre-conception. CHAP trial told us that for all chronic hypertensions, blood pressure should be less than 140/90, and lowering of BP in pregnancy in chronic hypertension is not associated with adverse fetal outcome. However, we know that in our patients, preeclampsia is also very common, and it is a real challenge to distinguish between preeclampsia and either a kidney disease flare or a lupus flare. And here comes the role of newer modalities. There are some which I have listed, some clinical parameters also, which we all obviously know. When a patient is having a preeclampsia on a superimposed kidney disease versus a worsening of kidney disease, classical symptoms of preeclampsia with associated features like HELP syndrome, high uric acid, and quick progression to nephrotic range proteinuria help us distinguish between these two complications. What comes to our rescue this and is now available not very commercially, but definitely for research setting. It is actually some labs are also doing it commercially, at least in Mumbai, are these biomarkers, thoroughly investigated, useful tools for evaluation of suspicion of preeclampsia. They are actually better than all the previous parameters which have been studied for diagnosis of preeclampsia. Very useful when you are with a patient who either has early stage IgA with early stage CKD or lupus, and you don't know whether the BP which is worsening is because of preeclampsia or worsening of underlying kidney function. Something which definitely needs to be considered, and we used to be using them more often now. We all know what the drugs are safe in pregnancies. It is important to correct the hypertensive emergencies because these are linked to progression more in glomerular diseases as compared to other CKDs. Obstetric considerations. The most important obstetric consideration is that monitor the fetal birth rate. Early loss of fetal growth is actually one of the earliest predictor of all the outcome problems and preeclampsia also. Delivery can definitely be vaginal, no need of any instrumental delivery, and it is ideal not to extend the pregnancy beyond 37 to 40 weeks. Beyond that, there is no added benefit to the fetus and there is added harm to the mother. Supportive treatment in nephrotic syndrome, like we do for all our patients. Edema can be very difficult to handle in these patients because in general pregnancy is an edematous state. They just soak all the salt and water around them. So diuretics can be cautiously added. We have already discussed VT prophylaxis. These are the cases who should be getting VT prophylaxis in pregnancy. Fibrates are safe. We still don't use them. Statin should be avoided. Aspirin definitely for everyone. Dietary consideration, that's the last slide. Nutritional deficiencies are common in patients with nephrotics because they lose nutrition in their with all the protein in the urine. So all the vitamin deficiency are common, which needs to be corrected. Excessive weight gain. Now in a nephrotic with pregnancy, it's very difficult to manage weight because we know with after mid gestation every week they are supposed to gain at least 300 to 500 grams. But whether they are gaining because of pregnancy or they are gaining because they are nephrotic, it's very difficult. But excessive weight gain needs to be avoided. Protein, this is from that Fakoriska recommendation. So they say that high protein diet should be avoided, but usually our population, they are usually not on high protein, very high protein. So we can just be liberal with protein intake. Every woman who has now gone through pregnancy and whatever the outcome has been, should be again counseled actively, proactively for contraception. We all know which is the best contraception for our patients, and depending on their hormonal profile, whether they are lupus or not, or what is their baseline metabolic mineral bone disease risk, we should be tailoring their contraceptions. this was that Asha Kumari. So actually what has happened is that she was a elderly 35-year-oldish kind of a lupus lady, name changed. Everyone, she knew that MMF needs to be stopped pre-pregnancy. She was told that. That was the only preconception counseling she had received. So she on her own stopped MMF and got pregnant. She took the liberty of taking that decision on her own that she stopped MMF. 2 months later, she got pregnant. She was in partial remission. Everyone counseled her against continuing the pregnancy. Definitely, it was not a very easy cakewalk, but then at the end, she did have a healthy baby to go home with a kidney function which has not declined too much from her baseline level. The reason why I had put this particular case is that despite all, like after listening to or seeing all the data, we might be discouraged that everything is like very, very difficult, and the easiest thing is to counsel them to not get pregnant or to abort when they get pregnant. But if we take the difficult road, it is a very rewarding thing. Dr. Rishi Deshpande sir was telling us that the budding nephrologists can take up onco-nephrology. So various people find satisfaction in various things. This particular act of giving a healthy child to a mother or to a family is very, very satisfying. If you can do even for 2 or 3 of your patients, that will definitely improve your overall job satisfaction a lot. So obstetric nephrology is something which is not considered in our country a lot. In West, there are clinics, multidisciplinary clinics which happen, maternal fetal medicine, neonatologists, gynec. Yeah, so I was just considering that obstetric nephrology should be given its due importance, apart from all the other things which we already discussed in this one. Thank you, sir.
Thank you for your comprehensive review. Whatever ends well is actually accepted well, but many times there are many ethical issues in a country where pregnancy is out of compulsion and a choice. I have a case where the patient got pregnant at the age of 55 out of in vitro fertilization, and I was called in the 7 months when she had a 10-gram proteinuria, and she delivered, and when she should breastfeed, she was on dialysis because of diabetic nephropathy. So this is the ethical issue whether she should have got pregnant itself or not, because can she care for those two? She had a twin pregnancy. And why she got pregnant? Because she had a son who died at the age of 25 in some Germany, and he came in her dreams and told, I want to come back again. And she got pregnant.
We will take one question.
So then I stopped considering that, and now I only tell them about the topic because people during the pregnancy if they get it.
No, you have to consult not only the patient, but the mother-in-law. So that is the most important thing in our country.
Yeah. So lots of data. Actually, recent data has come about candesartan used in Canada, US, that it is safe. There is data about captopril, which is safe, which we don't use. So if we take it as a class effect, ACRBs are safe during this period, and they can be immediately restarted if the patient has a pressing indication for that.
Thank you very much.